every drug goes through phases. Like a drug, an idea comes, the idea is criticized, or somebody thinks that this is going to be a brilliant idea. Then everybody thinks that this is possibly the best drug that humankind could ever think. And then suddenly the reports of some complications come up and they say that, oh, I won't give it to my dog even. And then comes a phase where we all come here, where we see that where exactly where we have to use. Fortunately for SGLT2 inhibitors, the whole history has happened within 10 years. Such a fast development. I think that is what that is interesting today. So my first expectation is SGLT2 inhibitors should exceed expectations. It is one thing to meet expectation, but it is something to exceed expectations. So it's always better to exceed expectation. I possibly believe that SGLT2 inhibitors belong here. So we all think that SGLT2 inhibitors is some small tubule, some small one receptor that is going to be inhibited. But unfortunately, we realize more and more it is almost affecting on every cell in the body, and it has actions. Multiple actions are there. I think we can't even go into the details of how it works in heart failure. We just don't understand how exactly it works in heart failure. And there are so many things that it can change in the myocardial metabolism, even in non-diabetics. Even in people who don't have diabetes, it is able to produce the kidney tubules. So many things. And there are multiple other mechanisms. It reduces systemic sympathetic stimulation. It improves a lot of systemic indirect as well as direct effects. I think it is really a panacea of possibly whatever is wrong in the new modern diseases that happen. I think it is possibly able to reverse it. That is why we are saying that whatever at times we have a lot of expectations, the reality may be really killing and we may fall flat. But what is the evidence? So there are two different clinical questions that are there. How good is SGLT2 inhibitors in terms of secondary prevention? How good is SGLT2 inhibitors in terms of primary prevention? So in secondary prevention, we are going to focus on people who have history of ASCVD in the form of either coronary artery disease, cerebrovascular disease, or peripheral arterial disease. Or in patients, generally it has been tested in not very young patients with diabetes. It has been tested in patients who have been long-standing diabetes with hypertension, dyslipidemia with smoking. And in the current generation of heart failure with reduced ejection fraction and preserved ejection fraction trial as well as renal protective trials, it has been tried even in non-diabetic population also. So what is the evidence? There are very many major trials now. So till 2020, we had these 8 trials, and from 2020 to 2022, right now, we have 8 major landmark trials. So I think we can't think of all landmark trials anymore in SGLT2 because everyone is a big landmark trial. So I will focus on, if I go to the evidence, there are some 333 is the hit that comes up in PubMed when you put SGLT2 inhibitors and systematic analysis and meta-analysis and systematic reviews. So there are more than 50 meta-analysis that have been published in SGLT2 inhibitors. So I will just focus on the recent meta-analysis and try to bring home the point. But unfortunately, the pointer is not working. So what I'm trying to say is the overall MACE is definitely reduced with SGLT2 inhibitors. When it comes to people who have ASCVD and people who do not have ASCVD, the below bar, clearly people who already have ASCVD, the MACE reduction is far more substantial than people who do not have ASCVD. That means primary prevention, still we need evidence in terms of MACE reduction. The same thing holds true in cardiovascular death also, where clearly the cardiovascular death is reduced overall, and in people who have ASCVD, it is clearly reduced, whereas we need more evidence when we want to do it, primary prevention, reduction in cardiovascular deaths. But interestingly, the same set of analysis gives different picture when you want to analyze renal outcomes and hospitalization for heart failure. In these two outcomes, even in patients who do not have established CVD, there also SGLT2 inhibitors are able to reduce heart failure hospitalization as well as the renal outcomes. So you can see the lower graph below. You can see clearly it is significantly different in people whether they have ASCVD or whether they don't have ASCVD. So possibly in the nutshell, as an evidence, we have clearly for severe risk reduction and MACE, we need primary prevention data is yet to emerge. We need more data for that. But for prevention of heart failure as well as prevention of renal related outcomes, clearly it works in patients who do not have ASCVD also. So another important thing is there are very many agents that are coming up now. We think that we should be better than because it is cheaper. So the GLP-1 agonists are very expensive. It should be better than them. So there is no randomized control trial, and there is possibly not anything that is going to happen comparing one agent with the other. So what is this is a recently published nested case control analysis from England and Wales NIH database. So around 300,000 patients have been treated without CVD. So all primary prevention sub cohort. I think this is what has happened. The MACE reduction was best with the combination of SGLT2 as well as GLP-1 group, whereas the heart failure reduction was substantial with even SGLT2 regimes. So a combination may be superior, but it is not too inferior comparing the cost. I think still is much better for heart failure hospitalization SGLT2 inhibitors. So it should even work in the highest risk patients with diabetes, where it has been always difficult. For example, statins have failed, aspirins have failed to prevent events in patients with diabetic CKD. So here again, there are a lot of demerits are there. Like for example, the glucose reduction, the HbA1c reduction is far lesser with SGLT2 inhibitors in patients who have diabetic CKD. And then there is slight increase, slight reduction in eGFR that happens with the initiation of SGLT2 inhibitors in this subgroup. But clearly the evidence suggests that the MACE effect is maintained, heart failure hospitalization is maintained, stroke events are lesser, it even reduces albumin-creatinine ratio also. So it's all endorsed, and this is a recent meta-analysis published in Lancet in 2022, clearly suggests that the kidney disease prevention and acute kidney injury, even if you don't have diabetes also, is clearly significantly superior with the SGLT2 inhibitors. So you have diabetes or no diabetes, these drugs are protective in kidney, and if you have a kidney disease, ASCVD risk is reduced. So I think our expectations keep on increasing. We want to comprehensively manage diabetes beyond HbA1c levels. So we want to correct everything that is possible. Do they? Do they correct? So they reduce a modest reduction in HbA1c, various agents that have been shown. But they have a substantial reduction in systolic blood pressure. So for the cardiologist also, these numbers may look diminutive, like 2 mm Hg reduction. If you look at AC inhibitors, they reduce it by around 4 mm or 5 mm Hg only. So I think this is decent amount of systolic blood pressure reduction, and they reduce weight, and more importantly, they have almost all the favorable effects on lipid metabolism that you want in a drug. So our expectations exceed now. We are trying out to prevent diabetes. We are trying it to work in non-alcoholic fatty liver disease. There are studies that we have also started in patients, children with heart failure with SGLT2 inhibitors. They have been shown to prevent gout. They have been treated as SADH. I think it's going beyond thing. But more importantly, we want lesser side effects. What are the data on side effects like? So UTI and genital infection have been in the Achilles heel of these agents, especially the genital infection. But the recent suggests that only there is a marginal increase in data. Increased amputation is primarily driven by canagliflozin data, canvas data, but rest of the recent data suggests there is amputation and fracture risk is less. Euglycemic ketoacidosis is a very fancy complication, but it is extremely rare in clinical practice. So the meta-analysis of safety suggests, very importantly, suggests that the favorable events are far outnumbered. For example, we prevent 9 MACE and we prevent 6 ESRD. At the same time, we have 3 more amputation and 2 more ketoacidosis. So finally, coming towards the end, we need more net benefits. So clearly, somewhere around heart failure hospitalization as well as cardiovascular benefits are around somewhere around 15 to 23% reduction. MACE is around 11% reduction, whereas kidney disease reduction is around 35% reduction, and severe hypoglycemia and all-cause mortality is reduced by around 13% reduction. At the same time, the increase is ketoacidosis, even though it is 2 times, the absolute events are far little, and UTI there is small increase. The only thing that definitely increases is again myocardic genital infections, and again there is a small increase in lower limb amputations. There is some recent meta-analysis suggests that Asians have far more benefits compared to the other Western population. So what are the net effects of these agents? So this is the various other things that have been tried out. Interestingly, one thing I want to point out here is that the event reduction, the net benefit is far more likely to be beneficial in even people who don't have diabetes or who have early diabetes because their complication rate is far lower. So final expectation from me is it should be affordable by all Indians. With the dapagliflozin, I think it has reached that where the cost of therapy has come down below 500 rupees a month. So I think with exceeding expectations is where the satisfaction ends, the loyalty begins. I think all of us will agree that the cardiologists have become loyal to this because SGLT2 inhibitors have been the molecule of this decade, and the nephrologists and endocrinologists are following the suit. Thank you.